Good day, everyone. I'm Leody Monteveros, and together with some of the members of Group 2, we will be discussing about Chapter 15, the meninges. Our objectives include the following. First, to describe the structure and function of the three meninges that surround the brain and the spinal cord, to determine the venous sinuses within the skull, and explain how the meninges contribute to their walls, and lastly, to identify the relationship of the meninges to the different forms of cerebral hemorrhage. For the order of our discussion, we'll start with the brain meninges, the dura, arachnoid, and the pia mater. Then we'll proceed with the spinal cord meninges, and we'll end with the clinical notes. So first would be all about the brain meninges. Meninges mean protective membranes, and both brain and the spinal cords are comprised of three layers of meninges or membranes. We have the dura mater, the arachnoid, and the pia mater. Now we'll proceed to the first protective membrane or meninx of the brain, which is the dura mater. The dura mater is made up of two layers, and we call it the industrial and the meningeal layers. Both layers are closely united to one another, but at times they separate, or at certain areas, they separate to form venous sinuses. And you can see here in the illustration the industrial layer of the dura, and then we have the meningeal layer of the dura. They are closely associated with one another, but at certain lines or certain location, like here, they are separated. The industrial layer is basically a periosteum covering the inner surface of the skull. And if you can recall, periosteum is a membrane that covers bones. So here we can see the industrial layer of the dura mater. And at certain sites in the skull, like in the foramen magnum, the industrial layer is not continuous with the dura mater of the spinal cord. And at around margins of all foramina, it is continuous with the periosteum. And at sutures or at the sutural level, it is continuous with the sutural ligaments. The meningeal layer is what we need as a dura mater proper. And here is the meningeal layer of the dura mater. And the same with the industrial layer, it is a dense, strong, fibrous membrane. And in contrast, it is continuous through the foramen magnum with the dura mater of the spinal cord. And it also provides tubular sheets for the cranial nerves. These sheets fuse with the epineurium or the outermost layer of the peripheral nerves outside the skull. As mentioned, you can see here that at the foramen magnum, the meningeal layer of the dura mater of the brain becomes continuous with the dura mater of the spinal cord. And here in this figure, the meningeal layer of the dura mater forms a tubular sheet, or it fuses with the epineurium of the peripheral nerves. And here's another image to better appreciate the industrial layer of the dura mater, and we have the meningeal layers of the dura mater. The meningeal layer sends four septa inside the skull. These are the falx cerebri, the falx cerebelli, the tentorium cerebelli, and the diaphragma cellae. In a while, we will be discussing each one of the septum. And the purpose of the septa is to divide the cranial cavity into freely communicating spaces. Additionally, it is there to restrict the displacement of the brain associated with acceleration and deceleration when the head is moving. In this diagram lifted from the book, we can visualize here that the tentorium cerebelli as well as the falx cerebri. Here's another image showing all of the four septa, the falx cerebri here, the falx cerebelli, which is a very small membrane compared to the others found here, the tentorium cerebelli, and also a small one, the diaphragma macalandag. The falx cerebri is a sickle-shaped fold, and it is situated in the midline between two cerebral hemispheres. Its anterior end is narrow, and it is attached to the internal frontal crest and crista galli. So this is the frontal crest and the crista galli of your anterior cranial fossa, while the posterior part is broad and it blends in the midline with the upper surface of the tentorium cerebelli. So it blends in this portion or area. It's also important to note that the superior sagittal sinus runs in its upper fixed margin here. The inferior sagittal sinus here runs in its lower concave free margins, and the straight sinus runs along its attachment, the attachment of the falx cerebri to the tentorium cerebelli. So it's in between. On the other hand, the tentorium cerebelli is a crescent-shaped fold. So this is the crescent shape. It roofs over the posterior cranial fossa. So this is your posterior cranial fossa here. And it covers the upper surface of the cerebellum, because below this membrane is already the cerebellum. And it supports the occipital lobes because it's also situated in the occipital area. As mentioned, the falx cerebri and the falx cerebelli are attached to the upper and lower surfaces of your tentorium cerebelli. And note that the straight sinus here, it runs along its attachment to the falx cerebri. The superior petrosal sinus here, it runs along its attachment to the petrous bone. And the transverse sinus here, it runs along its attachment to the occipital bone. And we also have this structure called the tentorial notch. It is a gap that allows passage of the midbrain. So this area here would be the tentorial notch, and it produces an inner free border and attached fixed border. So this would be the inner free border, and this one would be the attached or the fixed border. The falx cerebelli is a small sickle-shaped fold of dura mater, and it is attached to the internal occipital crest, and it projects forward between the two cerebellar hemispheres, and its posterior fixed margins contains the occipital sinus. And lastly, we have the diaphragma cellae, which is a small circular fold, and it forms the roof of the cella turcica. So the stalk of the hypophysis cerebri, or your pituitary gland, passes through the small opening in its center.
So, hello once again, everyone. I am Digal, and I will be discussing to you today the dural nerve supply. So, the dura mater receives nerve supply from the branches of your trigeminal nerve, your vagus nerve, your sympathetic nervous system, and the first three cervical nerves, which passes through the foramen magnum. Now, your dura mater possesses numerous sensory endings that are very sensitive to stretching, which produces the sensation of headache. So, stimulation of the sensory endings of the trigeminal nerves, which innervates the upper level of your tentorium cerebelli, produces referred pain to an area of the skin on the same side of the head, whereas the stimulation of the dural endings below the level of your tentorium, which is innervated by your cervical nerves, produces pain referred to the back of the neck and the back of the skull. So there are different types of headache mentioned in the book. The first one is your meningeal headache or your meningitis, which is the inflammation of your meninges that causes severe headache on your entire head as well as the back of your neck. The next one is the presence of your cerebral tumors. So if you have an expanding cerebral tumor, this increases or raises the intracranial pressure, which then causes continuous and progressive headaches. So if your tumor is located above your tentorium, the pain is in your forehead. Whereas if it is located below the tentorium, your headache is located at the back of your head. The third one is the most common type of headache, which is called migraine. So migraine can be unilateral or bilateral, and it is mainly caused by the dilation and stretching of your cerebral arteries. Now, to relieve the pain caused by migraine, patients are given beta blockers. The last but not the least is your alcohol. So the intoxicating effect of your alcohol causes severe headache. The next topic that I'm going to discuss is your dural arterial supply. So the dura is supplied by numerous arteries from the internal carotid artery, the maxillary artery, the meningeal branches of your ascending pharyngeal, occipital, and vertebral arteries, and the most important one, the middle meningeal artery. So from the clinical standpoint, your MMA is the most important because it is the most vulnerable to head injuries or traumas. So why? Why is it prone to head injuries or traumas? It is because the middle meningeal artery is located adjacent to the bone in the more lateral regions of your skull, and so it is easily damaged by head traumas. The blood accumulation between the dura mater and the bone creates increased pressure that may result in brain injury or death. So this is where my report ends. Now I will give the floor to Dr. Ryume Baluis to discuss dural nerve sciences.
Hello everyone, I am Ryume Baluis. So, to continue, let us discuss the dural venous sinuses. So, the dural venous sinuses of the cranial cavity are situated between the layers of the dura mater, which are the meningeal and the periosteal layer. So, their main function is to receive blood from the brain and the CSF and then drain into the internal jugular veins in the neck. They are lined by endothelium and they do not have valves. We also have here the emissary veins, which connect the dural venous sinuses with the diploic veins of the skull and the veins of the scalp. There are a lot of venous sinuses, however, we will only be discussing those that were mentioned in our book. So, we have the superior sagittal sinus, the transverse sinus, occipital sinus, inferior sagittal sinus, straight sinus, superior petrosal sinus, sigmoid sinus, cavernous sinus, and the inferior petrosal sinus. So, let us look into each of these. So first is the superior sagittal sinus, which occupies the upper border of the falx cerebri. It commences at the foramen cecum and run posteriorly, and at the level of the internal occipital protuberance, it deviates to either side and continued as the transverse sinus. So we can also see here the confluence of sinuses, which is the junction between the superior sagittal sinus, the straight sinus, occipital sinus, and the transverse sinus. Transverse sinuses are paired structures that begin at the internal occipital protuberance. So this right sinus is continuous with the superior sagittal sinus, and the left sinus is continuous with the straight sinus. Next would be the occipital sinus. It is a small sinus and occupies the attached margin of the falx cerebelli, and it begins near the foramen magnum, so here, and drains into the confluence of the sinuses. So ito siya from the foramen magnum and to the confluence of sinuses. Ito yung occipital sinus. Next is the inferior sagittal sinus, which occupies the free lower margin of falx cerebelli. So if merong superior sagittal sinus, meron ding inferior. So it runs backward and forms the straight sinus. So ito ang inferior sagittal sinus. It runs posteriorly, and this is your straight sinus. So, straight sinus is formed by the union of the inferior sagittal sinus with the great cerebral vein and ends by turning either way to form the transverse sinus. So, ito ang inferior, straight, then either way ay ang transverse sinus. Next is the superior petrosal sinus. So, this receives blood from the cavernous sinus and drains into the transverse sinus. It also receives some cerebellar and inferior cerebral veins and veins from the tympanic cavity. So, this is the superior petrosal sinus. Then, ito yung transverse sinus. So, then the sigmoid sinuses, which are a direct continuation of the transverse sinuses. So, they are also paired. So, ito yung sigmoid sinuses. Here, continuation siya ng transverse, and then this is the superior petrosal sinus. Next is the cavernous sinus, which is situated in the middle cranial fossa on each side of the body of the sphenoid bone. So, the structures that run through it are the internal carotid artery and the cranial nerves 3 to cranial nerve 6. And lastly, the inferior petrosal sinus. It is formed by the junction of the petrous part of the temporal bone with the basilar part of the occipital bone, and it drains the cavernous sinus into the internal jugular vein. So it was mentioned earlier na these sinuses drain into the IJV. So I will just show you the pathway of its drainage on how they reach the IJV. So, itong superior sagittal sinus, it drains directly to the confluence of sinus. Unlike the inferior sagittal sinus na it drains first to the straight sinus before to the confluence of sinus. And this confluence of sinuses drains into the transverse sinus, then to the sigmoid sinus, and then to the IJV. IJV to po. And then we have our cavernous sinus, which drains into either the superior or inferior petrosal sinus. And if it drains in the superior petrosal sinus, it drains first to the transverse sinus, while the inferior petrosal sinus drains directly to the IJV. And that would be all for the dural venous sinuses. Thank you.
And now, let's move to the second meningeal layer of the brain, which is the arachnoid matter. So, the arachnoid matter is a delicate, impermeable membrane that lies between the pia mater internally, which is separated by the subarachnoid space filled with CSF, and dura mater externally, which is filled by the subdural space. So the outer and inner surfaces are covered by the mesothelial cells. It is the arachnoid and pia maters are separated to form the subarachnoid cisternae. So these are the cisterna cerebromedullaris, which lies between the cerebellum and the fourth ventricle. So here is this one. And the cisterna interpeduncularis, which lies between the two cerebral peduncles. So they houses the CSF. The arachnoid projects into venous sinuses to form the arachnoid villi. So this aggregation, they form an aggregation called the arachnoid granulations. This one. So it is the site where the CSF diffuses into the bloodstream. Cerebral arteries and veins pass through the subarachnoid space. So the arachnoid matter fuses with the epineurium. So as we can recall, the epineurium is the outer layer of the nerve fibers, and the arachnoid matter fuses with it. So in the case of the optic nerve, the arachnoid forms a sheath and fuses with the sclera of the eye. So in this diagram. In addition, the CSF is produced by the choroid plexuses and enters the subarachnoid space. So it circulates both in the cerebral hemispheres and spinal cord and extends down. So here it extends down at the second sacral vertebra as pointed by the arrow. The CSF provides fluid medium which the brain flows. So in this picture, as you can see, it is something like an analogy of the brain and the CSF. So it protects the brain from the trauma, serves as a hormonal transport, and it removes waste products associated with neuronal activity. And that's it for the dura mater, arachnoid matter. And now let's move to the innermost layer, which is the pia mater. So it is a vascular membrane covered by mesothelial cells, also covers the gyri and sulci, and it forms the thalachoroidea of the roof of the third and fourth ventricles. So it fuses with the ependyma of the it fuses with the ependyma to form the choroid plexuses. And next subtopic of this chapter is the spinal cord lineages. So it is also the same as the brain's meninges, which is also composed of three meninges or layers: the dura mater, arachnoid mater, and the pia mater. So the dura mater is also a dense, strong, fibrous membrane which encloses the spinal cord and the cauda equina. So it is continuous with the foramen magnum with the dura mater of the brain. So the dura mater of the vertebral column, or the vertebral column, is continuous with the dura mater of the brain, and it ends on the phylum terminale. So it is separated from the vertebral canal by the extradural space, which contains the internal vertebral venous plexus. And now the arachnoid mater, the second layer or the middle layer. So it is a delicate, impermeable membrane that lies between the pia mater internally, which is also separated by the subarachnoid space filled with CSF, and dura mater externally, which is here. So it is continuous above the foramen magnum with the arachnoid mater of the brain. So it also ends in the phylum terminale. The innermost layer is the pia mater. So it is a vascular membrane thickened between the nerve roots to form the ligamentum denticulatum. So it is continuous with the connective tissue around the surrounding each spinal nerve. So just like the other meninges, it is also continuous to the pia mater of the brain and ends at the phylum terminale. So in this picture, it shows a dissection of the back of the head and neck. So the occipital bone has been removed, exposing the periosteal layer of the dura mater. So this is the periosteal layer of the dura mater. Now in this one, it shows also the dissection of the lower part of the neck, including the lumbar and sacral regions of the vertebral column. So the meningeal sheath has been incised and exposing the lower end of the subarachnoid space and also the phylum terminale. And that's all for my report. Thank you.
Good day everyone, this is Maria Alondra Macalandag and I will be discussing the clinical notes for Chapter 15. First, let's talk about the functional significance of the meninges of the brain. Why are these important? The tough dura mater protects the nervous tissue. It forms a protective sheath around cranial nerves as they exit the different foramina of the skull, and it also protects the roots of the spinal nerves. Here we highlight two important structures which are enfoldings of the dura mater between the cerebral hemispheres, which is the falx cerebri, and between the cerebrum and the cerebellum, which is the tentorium cerebellum. Together, they limit excessive movements of the brain within the skull, like how a seatbelt secures a passenger onto their seat. Next is the arachnoid mater. This is much thinner than the dura, but it is impermeable. An important potential space here in green is the subarachnoid space between the arachnoid and pia mater. This space is filled with CSF, which gives buoyancy to the brain, and it also protects the nervous tissue from mechanical damage to the skull. The pia mater is a vascular membrane and it is perforated by numerous blood vessels which supports the brain and spinal cord. Now, what happens if the brain moves excessively around the skull? First, let's see how different bodily movements affect the position of the brain. Imagine you are riding the bus home and the bus is moving near the speed limit and suddenly, the driver hits the brakes. Notice how your body continues to move forward due to inertia, and you would probably hit what is in front of you. Similarly, when the body is moving forward or backward and then suddenly stops, the brain resists this sudden stopping motion due to inertia, hitting the skull. And this may occur during whiplash injuries. For lateral movements, the brain will also collide against the skull, and this happens with a coup or contre-coup injury to the brain. If it is a coup injury, the brain hits the side of the skull where the impact is applied. A contre-coup injury occurs if the brain hits the side of the skull opposite to the impact, but these two can also occur together, such as in a coup-contre-coup injury to the brain. Superior movements, up and down movements, will also cause the superior structures of the brain to collide against the vault or the base of the skull. You see, even though the brain has protective structures, if the movement is excessive, cranial nerves may be injured. The fragile cortical veins may also be torn and cause subdural or subarachnoid hemorrhage. The subdural and subarachnoid hemorrhages, along with epidural, are types of intracranial hemorrhage. Epidural hemorrhage is caused by injuries to the middle meningeal artery due to blow to the side of the head or the parietal bone. We also recall that a common site for MMA injury is beneath the therion, which is the thinnest part of the skull. Bleeding occurs above the meningeal layer of the dura or the true dura and below the periosteal layer of the skull. The subdural hemorrhage is caused by the tearing of superior cerebral veins due to a blow on the front or the back of the head, causing anteroposterior displacement of the brain. Bleeding then occurs below the dura, above the arachnoid mater. And third is the subarachnoid hemorrhage, which will be discussed in Chapter 17. On the CT scan, you can identify epidural hemorrhage as a lens-shaped hyperdense collection of blood. Hyperdense meaning it appears brighter than the other structures on the CT. As bleeding continues, it strips off the meningeal layer of the dura, and the ICP rises, which exerts local pressure on the motor area in the precentral gyrus, which will produce symptoms. And because blood is pooling on one side of the head, the midline structures will be displaced to the opposite side encircled here, and it also compresses the brain. Notice also that there is a fracture line and blood passes through here, causing swelling under the temporalis muscle. The subdural hemorrhage can be identified on the CT scan as a crescent-shaped hyperdense collection of blood. Hyperdense if it is acute, and if it is hypodense, which appears darker, the hemorrhage is chronic. And if the hematoma is large, the brain sulci will be obliterated, meaning the characteristic folds of the brain will disappear, and midline structures will also be displaced. This slide here summarizes the key differences between the subdural and epidural hematoma. First is the injured structure. If it is epidural, MMA is injured. If subdural, the superior cerebral veins are injured. Second is, where does the swelling occur? Epidural is between the meningeal layer of dura and the periosteum of the skull. If subdural, it is between the dura and arachnoid. Third is the shape. Epidural appears lens-shaped on the CT, while subdural is crescent-shaped. Intracranial hemorrhages can also occur in infants whose skull have not fully ossified yet, so it is soft, and it may result from the excessive molding of the head, like when a baby's head is vacuumed to aid in delivery. And if compression becomes excessive, it can actually tear the tentorium from the falx cerebri, and the deep veins of the skull may be damaged, causing bleeding or hemorrhage. The shaken baby syndrome was also mentioned, and it is actually the most common form of abuse against children up to 3 years of age. Even if a hematoma does not occur due to shaking, diffuse axonal injury may occur, which directly damages the neurons of the brain. And if a baby is shaken violently, these following symptoms may occur, and in severe cases, the baby may be unresponsive, with bulging fontanelles and retinal hemorrhage. There will also be blood in the CSF, hemorrhage, as we've mentioned, and it may ultimately lead to death. And autopsy often reveals that localized subdural hemorrhage occurs in the parieto-occipital region, and there is also subarachnoid blood associated with massive cerebral swelling and neuronal loss. So please, babies are fragile creatures. Don't shake them. And that would be all for this chapter. Thank you very much and good day.